برحب بحضراتكم جميعا. دلوقتي هنبتدي السيشن 31 بعنوان Challenges in the Management of Type 1 Diabetes in Adolescents، وهنبتدي بالأستاذة الدكتورة شيرين عبد الغفار، أستاذ طب الأطفال والسكر والغدد الصماء جامعة القاهرة. هنبتدي بالمحاضرة عنوان Interplay of Puberty with Type 1 Diabetes. اتفضلي دكتورة شيرين.
شكرا دكتورة غادة على التقديم، وشكرا للدكتورة إيناس شلتوت على المؤتمر الرائع ده وعلى دعوتي ودعوة أساتذة الأطفال السكر والغدد الصماء للمشاركة. أنا سعيدة جدا طبعا إن أنا مع زملائي أستاذة الدكتورة منى عطية، أستاذة الدكتورة غادة أنور، أستاذ الدكتور أشرف الشرقاوي، وطبعا التشير بيرسونز والدكتورة إيمان الشريف. وجميل جدا إن احنا نتكلم النهارده على الادوليسنس وعلى البيوبرتي اللي هي كومن ما بيننا وما بين الادلت دايابيتولوجيست، وبحيث ان احنا دايما يكون في انتراكشن بيننا وبين بعض لصالح المريض. فاسمحوا لي اتكلم عن lifelong challenges for diabetic adolescents and the impact of puberty on diabetes, whether on the onset of diabetes, on the glycemic control, on the chronic complications, acute complications, other aspects, and also on the impact of diabetes on puberty. So, of course, everyone who is familiar with diabetic children knows the lifelong challenges, like receiving multiple daily insulin injections, having to do frequent pricking with self-blood glucose monitoring, the dietary restrictions, the lifestyle modification that we ask them for, and to help them to overcome the threat of the acute and the chronic complications. There are extra challenges in puberty or in adolescence because the adolescent is not a child anymore and not yet an adult. He is in a state of emerging adulthood. So this makes an extra challenge in this age period. Puberty, there is an ongoing physical and biological maturation, but there is also changes regarding social, cultural, mental, and psychological changes. So let's start with the impact of puberty on diabetes. First, there is reported higher incidence of new onset of diabetes, whether type 1 or type 2 diabetes in puberty. Second, in puberty, there is poorer glycemic control. There is accelerated development of chronic complications, higher incidence of acute complications, psychosocial disturbances, higher incidence of substance use and abuse like smoking and drugs, which have an impact on diabetes, of course. And finally, these children during puberty, we lose them in the follow-up care. So we have to work on that too. So regarding the incidence of new diabetes, all the studies have reported that the incidence of type 1 diabetes in the pediatric population has increased substantially in the last 50 years and is expected to increase further in the next 15 to 20 years. And the highest incidence is around the age of 10 to 14. What about the glycemic control? At puberty, deterioration in the metabolic control is attributable to many factors. Endocrine changes leading to increased insulin resistance, erratic meal and exercise patterns, poor adherence to treatment regimens, eating disorders, hazardous and risk-taking behaviors, increase in the weight gain, particularly in females, sometimes observed, provoking insulin omission to lead to weight loss. During puberty, the energy intake and the nutritional demands increase substantially. There is high incidence of obesity and there is significant increase in the insulin dosage. And the increased sex hormones lead to insulin resistance. Very often we see this picture in adolescents with the acanthosis nigricans and with the very high insulin doses and the poor metabolic control. And there is high incidence of obesity and overweight, which is about 30% in this age period, which also leads to some sort of poor metabolic control. The overweight and the obesity can be attributed to the high energy intake in this age period, the intensive insulin therapy, and we all know that insulin increases the appetite, it increases the lipogenesis, the excessive exogenous insulin, the autoimmune hypothyroidism that may be associated, the eating disorders, or it may be a part of polycystic ovarian syndrome due to the hyperandrogenism which occurs during this age period, which may be associated with the hirsutism and abnormal uterine bleeding. These children or adolescents in puberty, they like to stay out late with excessive afternoon or evening snacking and eating out with friends, taking more and more doses of insulin. If they perform competitive sports, this may lead to hyperglycemia, which also necessitates extra doses of prandial insulin, which leads again to poor metabolic control. The lack of motivation, the stubbornness, the rebellions, the depression and anxiety, all of these are factors which contribute to the poor metabolic control in this age period. Let's go now to the accelerated development of chronic complications. Puberty is considered as an accelerator for diabetes complications, and this figure shows how in puberty there is increased secretion of growth hormone, and this growth hormone leads to insulin resistance and leads to increase in the adipose tissue, and also in females may lead to hyperandrogenism due to affection of the LH-FSH secretion. And of course, the insulin resistance promotes the vascular complications, and all of these actually are interrelated together. The insulin resistance of puberty, of course, leads also to what is called the metabolic syndrome, the dyslipidemia, and the high incidence of cardiovascular complications. And of course, many studies have been done, and this is a systematic review that I have done in 2009, elaborating on the effect of metformin added to insulin therapy for type 1 diabetes in adolescents to increase the insulin sensitivity. That is a problem, actually, the insulin resistance in this age period, and is the platform for all the diabetes complications. Yes, the studies, the SEARCH study have documented that fatty liver disease is more common among obese children with insulin resistance and diabetes, and that there is increased prevalence of cardiovascular risk factors like hypertension and dyslipidemia related to obesity, the microalbuminuria in adolescents, 10% incidence in type 1 diabetes, the neuropathy, 20% incidence in adolescents with type 1 diabetes. And of course, the screening protocols for the microvascular complications are so much taking care of the pubertal age. At the pubertal age, where there is acceleration of the complications, the screening should be more vivid and more comprehensive for these children. And as you see here, the incidence of retinopathy and albuminuria is higher among pubertal children than in children younger in age. And also this figure also comparing the different Tanner stages as regard the retinopathy and the microalbuminuria, it shows at the extreme right that in the Tanner stage 5, yes, the retinopathy and the microalbuminuria are at their highest prevalence rates. The research is all now concentrating on this age period and the complications that are accelerated in this age period. Is it only about the chronic complications? No, it's also about the acute complications, where there is higher incidence in puberty, whether the hypoglycemia or the diabetic ketoacidosis. Concerning the hypoglycemia in adolescence and in puberty, there is impaired glucagon response. There is early loss of glucagon response leading to defective counter-regulation. And so in this age period, we encounter frequent hypos and we encounter hypoglycemia unawareness, which has to be properly cared for. Concerning the DKA, the admission rates to DKA in type 1 diabetes aged 15 to 25 years are much higher than the age period below. So actually all the diabetes complications, whether the acute, the chronic, whether the microvascular or the start of the macrovascular complications, they are all actually accelerated during puberty. Let us go now to another aspect which also affects the diabetes control, the psychosocial disturbances that occur in this age period due to the hormonal imbalance that happens around the puberty. Yes, these children in this age period are susceptible to anxiety disorders, which can complicate the self-management of diabetes. Depressive symptoms is very common. It accounts for 15 to 33% of adolescents, including 18 to 20 years, suffering from depression, of course, because diabetes is a chronic disease with all its burdens and with all its challenges, can lead to psychosocial problems if not dealt with properly. Having a psychologist or a psychiatrist among the diabetes team. And of course, the eating disorders, whether the anorexia nervosa or the bulimia nervosa, it has a psychosocial background, and it's common also in this age period. And of course, it complicates the management of type 1 diabetes in this age period. Let's go to another aspect, the substance use and the abuse, the smoking and the drugs. And of course, it's very common in our community, although it's considered as a taboo and we don't have like good, accurate statistics about these problems, but it's there. And everybody who sees these children in this age period knows that the smoking, the drugs, they are common in this age period. And of course, it increases the cardiovascular risk and the risk for microalbuminuria. And at the end of the day, all these problems and all these social, cultural, psychological, biological changes which occur in this age period, if we don't treat these children or adolescents differently, they are not children and they are not yet adults. If we don't pay to them enough care, actually there is loss to follow-up care. We lose them in our system if we don't put the light on the importance of this age period. And if we look to the other side of the coin, is there an impact of diabetes on puberty? Yes, of course. The poor metabolic control can suppress the growth and puberty in these children. And there has been like a syndrome very well known in the past, like Moriak syndrome. Of course, we don't see it now commonly because of the technology and the advent of new insulins and the better diabetes care in our community. But actually, we still see them. If you look to the growth curve on the right, you see this girl who had a long duration of diabetes of like more than 5 years, and she was very poorly controlled. You see how the height is going down. She has short stature, and how the weight is going down. And in addition, she has delayed puberty, she has hepatosplenomegaly, and she has microvascular complications. Why? Because the increased levels of the advanced glycation end products, they suppress the activation of the gonadotropin releasing hormone pulse generator, resulting in pubertal delay. So in conclusion, adolescence and puberty is a critical developmental phase that presents unique challenges and opportunities to individuals with diabetes, their families, and also to us, the healthcare providers. Successful treatment of type 1 diabetes is of particular importance during puberty for the achievement of normal growth and sexual maturation, and also to reduce the risk of long-term vascular complications and improve quality of life of these patients. Of course, this needs a multidisciplinary team approach, needs the diabetologist, whether a pediatrician, the internist, the family physician, the nutritionist, the dietitian, the psychologist, other healthcare professionals, and of course, the role of the diabetes educator is of utmost importance. I would end with this quote, which says that optimal healthcare is achieved when every person at every age receives healthcare that is medically and developmentally appropriate. Thank you very much. And I'm so pleased to get all your questions at the end of this session.